Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. Thanks for joining us for today's live webinar, Ultrasound for Accurate MSK Injections and Interventions Part 3, the Achilles. You're among 2,800 clinicians who registered for this popular session. It's been exciting to work collaboratively with the fabulous Dr. Alan Hirahara on this three-part ultrasound webinar series for guiding efficient and effective procedures. In this cadaver series, we've been able to cover such a wider variety of procedures to fast-track our learning curve with ultrasound-guided techniques for the shoulder, knee, and today for the Achilles. If you missed the first two webinars in this series, you can watch them on our website at clarius.com/webinars. We'll be joined again shortly by Dr. Hirahara, who is board certified in both orthopedic surgery and sports medicine. Using his Claris L15 HD3 and a cadaver ankle, he'll use video to teach us expert techniques for identifying anatomy, planning our injection, and visualizing our needle for fast, accurate Achilles injections, ensuring that pain medicine injections are peritendinous or that biologics are placed precisely at the site of injury. Please use the Q&A icon at any time during today's session to ask questions, which we'll address in a live session following the presentation. Let me now introduce you to your host for today's webinar. Shelley Gunther is an experienced sonographer with over 25 years of experience as a clinical ultrasound expert. As clinical manager at Clarius, Shelley is dedicated to providing the highest quality educational content for clinicians looking to add point-of-care ultrasound to their practice, delivering practical webinars like today's, and also working on video tutorials for our Clarius Classroom, which now features over 200 on-demand videos. Join me in welcoming Shelley.
Thank you, Jeunesse. I'm really happy to be here for the third installment in a series of webinars with Dr. Hirahara. Another great topic using ultrasound to image and guide injections into and around the Achilles tendon. I love imaging the Achilles tendon. It's one of those big, juicy tendons that images well almost all the time. So for learners, it's a really great place to start if you want to learn the ultrasound characteristics of tendons. Now, there's more and more literature available about the use of ultrasound to guide procedures as the techniques evolve and ultrasound becomes more well-known and, of course, more readily available. In this first paper from the Journal of Ultrasonography discusses the treatment of chronic Achilles tendinopathy to address the overuse condition in a growing number of adults who are participating in sporting activities. And I'm certainly one of those that feels the pain. So the therapy or injection needs to be accurately placed between the anterior aspect of the Achilles tendon and Kager's fat pad for maximum effectiveness. And ultrasound certainly contributes to the high volume injection ending up in precisely the right spot. This very recent article from earlier this year describes the technique for a PARS Achilles repair for tendon rupture. This is a minimally invasive surgical technique used to minimize the risk of wound complications seen with open Achilles repair. We continue to hear from experts that when this procedure is performed with ultrasound guidance, the accuracy increases. And fortunately for us, Dr. Hirahara will be demonstrating this in his presentation. And finally, this fantastic article from the American Journal of Radiology that reviews a wide variety of tendons and treatments, including the Achilles. It's well worth a read. The authors focus on ultrasound guidance to improve the accuracy of injections by visualizing the target anatomy and adjacent structures, the things that you want to avoid. The availability of handheld ultrasound has certainly broadened the use of ultrasound to specialists like yourselves so that you can be more accurate in your injections. Now, before we get to the meat of the presentation, let's put out a quick poll to all the practitioners attending from all over the world, all walks of life, all various areas of practice. We're curious to know, how often do you use ultrasound to guide your procedures? Is it something that you use daily or that you're just learning today? Are you a new user? You're just getting used to it? Or is this something you use in your daily practice? We'll close out the poll in just a few seconds. 3, 2, 1. Wow, so pretty even across the board. I'm so happy to see that there are quite a few people that use it daily and at least weekly. And if you're just learning today, like I mentioned, the Achilles is a great place to start, just to learn the characteristics of imaging the tendons, and just because it's so big and you can see the sheath and all of the fibers within it. So great. All right. So for today's webinar, we're excited to be welcoming back Dr. Alan Hirahara, who is board certified in orthopedic surgery and orthopedic sports medicine in the US and in Canada. And he completed his residency in Montreal and medical school in San Francisco. Dr. Hirahara runs a busy private practice in Sacramento and lectures and teaches around the world. He does research and publishes arthroscopic shoulder and knee surgery, ortho biologics, and the use of ultrasound. He's a team physician for the Sacramento River Cats and California State University. And Dr. Hirahara was appointed to and currently serves on the prestigious NCAA Committee of Competitive Safeguards and Medical Aspects of Sports. So Dr. Hirahara, we'll hand it over to you.
Thanks, Shelley. And yeah, it was great fun working with you and creating these videos and getting into the lab and messing around with all the cadaver parts. I found it kind of funny that you guys had really never done that before. And it's like, this has been fun because it's something in orthopedic surgery we do all the time. And we use as, teaching models for surgeons to work with and get better. So today we're going to talk a bit about the Achilles and my disclosures. And of course, our objectives, as Janez talked about already. But really kind of like, in terms of, I hope a lot of these people that are coming in today have actually been at the other ones, because this story comes back over and over of like, why did I get into ultrasound? And really biologics is what got me into ultrasound. So I figured we should probably talk a bit today, because we've talked about before on the other during the series about like, how it's better, how it helps, how it gets better localization, techniques to improve to get it there. But really, at the heart of it, I think something that everyone needs to start looking into is how we can harness the body's own power of regenerative and healing properties. And if we can understand it, how can we use it to focus on areas where maybe we're having trouble getting healing or getting trouble with other factors? Because I think for me as a surgeon, biology is becoming the limitation. Our limitations of being able to visualize, our limitations of being able to diagnose and identify, our ability to now surgically go in and have very strong techniques, strong anchors, strong sutures. We're hitting our limit at our ability sometimes to get a mechanical hold in place. We've got that. Now we're finding that biology and people's own inability to heal is what we're kind of running up against in terms of how we can be the next generation of getting people better. So just a small thing about this. As we all know, the whole healing cascade goes injury, inflammation, proliferation, and remodeling. And within that, during that inflammatory process, our body responds initially by having the platelets start and initiate the clotting cascade, that platelet aggregation, fibrin clot, and release of anti-inflammatory cytokines that have been actually started with white cell activation. And so the platelet is kind of like our kind of go-to as starting the process of healing, stops the bleeding, stops the process of inflammation, starts the process of regeneration by signaling the stem cells. And it really is the stem cells that do the heavy lifting and the work of regeneration. And so we have to understand that it's not the platelet that actually does regeneration, but the stem cell, which is what migrates and proliferates. And whether or not it proliferates or has an ability to message and transform localized tissue is currently controversial. That whole how concept is not really well known, but that's something that's coming for now. But we know that the white cell and the complement system, for the most part, is not really involved in the healing process. Their job is defense. Now, that, of course, is not entirely true. Monocytes are being shown to be involved in the healing process, but that's a smaller component. But the bottom line is, this is where we should start. This is what we have to know. And that's why the basis of platelet-rich plasma or stem cell aspiration or harvest and then plantation is critical, because we can then take the aspects of the healing that we want, put it where we want it, start the process. So, of course, that brings up the concept of leukocyte-rich versus leukocyte-poor. This is very controversial as well, whether it's preferable for healing. In my world, in surgery, white cell inflammatory response is bad. It increases inflammation, it increases pain, increases cell death, and most importantly, what I found, and I'll show you this a little bit later, is that it creates a zone of weakness. And in terms of using healing tissue and strong sutures, you're going to get detrimental, actually ripping and tearing of the tissue, and that's a big problem. So for the most part, I use leukocyte-poor PRP, platelets that modulate the inflammatory response, decrease inflammation, decrease pain, promote stem cell migration, create vascular channels, and inhibit bacterial growth. So this is something that we know is of benefit. And so for me, that is what I use primarily. Not using lidocaine or cortisone, and we've discussed this in other segments, how there's a cytotoxicity of the lidocaines, and of course cortisone very much diminishes the response of our healing, and so therefore is not of benefit, whereas things like platelet-rich plasma can help with tenocyte proliferation, whereas cortisone and the caines very much diminish that. So the question that always comes up to people that come to me goes, well, orthobiologics, it's investigational, it's experimental. No, it really isn't if you think about it, because realistically, all orthobiologics is using the body's own natural processes and understanding them, which we already do. Do we understand everything? No, we're still learning a lot more, but we do know the body is able to heal. Therefore, we know all we have to do is take that potential. We know that PRP was first described in the literature in 1969. It's been used for many decades. And frankly, PRP was FDA approved for the US in 1999 for use with autograft allograft in an orthopedic application. So we know this is something that does work and has been very much useful and beneficial. Understanding how, why, and in what use it should be done technically is what's critical. And that's why there's been so much variability between the outcomes of what people say it works or doesn't work. If you do it wrong or do it in an area that's not going to be helpful, it won't work well. So, but we do have level 1 evidence now. We know that PRP is beneficial in patellar tendinopathy, beneficial in partial cuff tears, beneficial in DJD, even superior to HA and placebo. So we know that this is something that helps our patients. And so we just have to understand how to do it correctly. And there's this big fiction that orthobiologics are going to make me heal better, stronger, faster. No, that's not the case. Because again, this is just simply initiating the cascade where we want it, diminishing inflammation and pain, and using the body's anatomy and own system to help promote that healing and diminish the chance of failure. So another fiction, orthobiologics have no complications. Well, again, not true. And I kind of alluded to this. I actually looked at this on PRP and posture repairs in the shoulder. We found that actually posture repairs with leukocyte-rich PRP concentrated very much gave a problem. And having that inflammatory response allowed for cut through of our high tensile strength sutures through the tissue. And so we found, which never occurred before in any time I've ever seen this, and the minute we stopped using leukocyte-rich PRP, this complication completely went away. So there's other complications, of course, with nerve damage, pneumothorax, and that's, of course, avoidable with injections if you simply just apply using ultrasound. And that's kind of the next key point, is that ultrasound is a critical component to biologics. And that's why I got so involved in using ultrasound. Because if we look at things, I used to just get an MRI and say, okay, is there a tear? I didn't realize that you can actually look at the architecture of a specific tissue and decide, is the architecture not just torn, but damaged? Is it edematous? Is it swollen? Is there an acute process? Is there a chronic process? It's something that you can really identify very well with ultrasound. Here's an example of a patellar tendon that's normal. And of course, here's one that's inflamed. You see a fusiform swelling with an area of edema with hypoechoic dark signal in the center of it. And of course, here you have a partial tear. in one area. In fact, we can now put a needle directly into these areas using PRP, which you could never do with cortisone, because if you put cortisone into that tendon, you're going to increase the risk it's going to rupture. So cortisone is very bad to put into a tendon. And if you do it blindly, you might be inadvertently putting cortisone into a tendon as opposed to peritendinous, where you have to put it. And now you're endangering and doing harm to your patient, and that is not appropriate. So that's kind of why, for me, biologics was how I got into ultrasound and why it was so critical for me. And then as we started doing more and more, we started really applying it and using it more. So we did this MRI analysis back in 2018 of the pelvis, because when I started doing more and more stem cell application and usage, we started looking into like the basic technique of taking the bone marrow aspiration and realized there was nothing out there. There had been no study looking at ideal way and technique to actually aspirate bone marrow from the pelvis. And so we did it ourselves, and we started looking at an MRI analysis, and we realized there was actually a specific, safe way that could be done reproducibly that would completely minimize risk to the patient and, of course, complication risk for these doctors using it. So what we realized is that with bone marrow aspiration from the PSIS, so coming posteriorly on the pelvis, that PSIS is a table, not a point, and that average table width was 1.08 centimeters. We realized that if you enter the PSIS from the most medial aspect and take a specific trajectory, very predictably, you can get a very far throw. And we know that the stem cell niche is basically a perivascular, pericortical type of area. And so therefore, that's why there's so much more stem cells in this region than almost anywhere else in the body, excepting of fat, because you've got two cortices right there. And so this is the ideal location to take your stem cell harvest. And so the problem is, if you come in straight in from your table, you have at most 3.2 centimeters until you're going to hit, coming in perpendicularly, you're going to hit your SI joint. And if you break through that cortex, you're going to damage the SI joint. So that's not good. And of course, if you take this angle, you can have up to 7 centimeter of a throw. That means you're going to get much, much better harvest of your stem cells. You're going to be a much safer area, and you can go much deeper and get a better harvest on this. So what we found is that we used ultrasound to identify the entry point reliably and predictably and easily, so that you're not going to enter into the sacrum, you're not going to hit a nerve, you're not going to hit a vessel. So it's very simple and reproducible. So you can hit that medial aspect, come into that PSIS at an angle of 24 degrees. And if you do that, you're going to be able to then go 6.7 centimeters on the female and 7.53 centimeters on the male as your average distance until you were to hit the far wall. So you have a very, very far and safe area to get through. And that's, of course, as opposed to coming perpendicular, we only have 3.2 centimeters. So the point I'm trying to make is ultrasound made this easy, safe, and doable in a clinic setting. It doesn't have to be done in the OR. So I know, long setup to get to the Achilles tendon, but the reality is that I was getting too many questions as to why I use ultrasound. And of course, you can talk about, accuracy, talking about safety, but really it actually opens the door to better treatment of patients in so many different ways. And that's why a shoulder knee guy is talking about the Achilles today, because that's just how easy this is. This is not something that's difficult to do. And once you become good with ultrasound, you can pretty much do just about anything in the body in terms of being able to, if you can visualize it, you can put a needle there, and safely too, making sure that it's okay to do. So here's an example of an Achilles imaged on July 18, 2018. We'll come back to why that's important. And you can see that the Achilles has a very large hypoechoic area. And you can see that the insertion is not very good. And it's very swollen, big tendon. And it's approximately 6 millimeters in terms of its diameter. And if you compare it, and this is the other ankle of this patient, which was only 3 millimeters. You can compare the two sides and see the difference between them. And this is something that very much hurt a lot and was a big problem. And so we were able to do PRP and put it directly into that hypoechoic area. And if you take a look at this from before and then after September 7th, so just simply 6 weeks later, you can see the huge improvement in this. And the reason why this is so important is because this was my ankle. This was my Achilles. And so if anyone ever doubts, the veracity of using biologics or ultrasound, trust me, let someone put a needle into your Achilles and it doesn't feel good. So you better make sure they get it right. And if someone's going to be paying actual cash to do a biologic, which because a lot of it still is not covered by insurance, you better do a good job and you better make sure it works. So to me, you're incumbent as the physician to not just always do a good job, but especially if someone's going to have to pay you cash for this, you don't want them to have a bad outcome. Now, of course, we always want a good outcome. I know that, but still, it's really important when this person's coming in looking for something and they're going to try to get you to get them better. So here's a few more examples of different pathologies. In fact, Shelley, I think this was one of your patients. Can you tell us some history about it?
Yes, this actually was a neighbor who I kind of asked to come over and scan his anatomy once in a while, but he had been complaining about his Achilles was a little bit sore after a hike. And then when I asked him a little bit more, he said that, oh yeah, I do remember injuring it about 10 years ago and eventually it got better. But it was bothering him a little bit again.
So it's interesting actually, because Shelley and I were talking about it. She showed me these pictures before, and of course she didn't give me any information. And she's like, well, what do you think of this? And I'm like looking at it going, well, I don't see any edema. There's not a lot of swelling fusiform of the whole tendon. I don't think this is an acute injury. You see a definite defect, hypoechoic defect right in the center, and it's well circumscribed. And so from my point of view, this is more of a chronic injury, something that's old. It might bother him on occasion. This is something that would have been completely missed on an MRI and clinical exam and only seen really on ultrasound. And this is something that if they were bothering him, absolutely doing an injection directly into that spot would be appropriate. Of course, if it doesn't bother him enough, doing therapy and just letting him live with it as he has for years is appropriate too. But I just thought it was really funny how, when you really can evaluate the ultrasound well, you can actually almost predict what the history is just based off the look of the actual image. Would you say, Shelley?
Yeah, for sure. And, when you say you may have missed it on the MRI, is that just because we just have better resolution with the ultrasound?
Absolutely. In fact, we're going to look at one here real soon. I have an MRI showing you that comparing the ultrasound, the X-ray, and the MRI soon with one of my patients. We'll come up to that case. And honestly, I find that the MRI is not always as easily seeing things, especially when it's chronic, because, when something's acute on MRI, where you can see on the T2, the edema, it really becomes almost obvious. When something's chronic, it's much harder to see, in my opinion.
And I also find too, sometimes it's positional with the patient, not so much the Achilles, but for other joints too. I mean, sometimes, when you make a slight movement on the patient, the pathology pops into view, whereas you may not see it in a certain position.
Yeah. And I think you did such a stellar job on this imaging because this is clearly a small area. It's a small little tubular area of damage. You can see that on the short. And to be able to see it image the entire length on the long axis, that's pretty remarkable. That shows good skill, Shelley. Sorry about that, but you did a great job.
Skills. Thanks.
As always. So here's another one, and you can see that this is different. So you can tell the difference. So if you look on the long axis, you can see how there's very much a fusiform swelling there in the middle. You can see how it's very hypoechoic on the superficial aspect, near the skin, and you can see also it really kind of sits towards one side on the short axis, and you can really tell that this is something that's probably more of either a clear tendonitis situation of one area, or might even have been a partial tear of just a small segment of the Achilles. And it's hard to say, but this is something where getting the history helps, but you can actually recreate it just looking at the images and just understanding all of it. So that's where I think having the ultrasound be able to really much see the subtle fibers, I think is really critical. So that's, I think, nice here. Do you have anything to add on that one, Shelley?
No, I think I find it really interesting how sometimes when the scanning in the long axis, if you're not right over the area, and as soon as you turn into the short axis, it's like, oh, well, that's because it's not center. It's a little bit off to the right or the left, but it definitely jumps out at you once you look at it in both planes.
And that's why I think scanning through the entire section, it really helps, up and down, back and forth, just check the whole thing. I think one of the biggest mistakes I've seen a lot of new users do is that they'll just slap it on, and the minute they see the tendon, they're like, oh, it's fine. Okay, nothing there. All right, it's fine. Or they'll see a tear and like, oh, there's a tear. Okay, but done. And you really have to scan through it to be able to get a three-dimensional aspect of what it's all about. And that's, I think, part of the problem that we've had with MRI is that if you don't scan through all the images, you miss it. Ultrasound's no different. You have to scan through all the sections and be able to identify all the different parts going from front to back.
Absolutely.
So, okay, so here's that one I was talking about. So you can see the X-ray right in the middle, and you can see on the X-ray, actually, you can see some calcification there just above the calcaneus. And if you look at the MRI on the right, you can actually see very clearly within the Achilles, just like how fusiformly swollen it is there on that one section, right? But then on the axial cut, you can see that there's definitely a kind of heterogeneity of the actual tendon. But not until you slap the ultrasound on is it becomes so obvious what's going on. And it's really interesting, in my opinion, taking a look at these ultrasounds and how, my goodness, like it's just peppered with calcification throughout the entire tendon. And I'm looking at this, and I remember this case, and it got sent to me to do PRP, and I'm looking at it like, yeah, I can do that, but I'm not sure it's going to work so well. I think this guy would do better off from actually a surgical debridement. So actually, I sent him back to the foot and ankle guy, going, okay, thanks, we can try the PRP, but I really think you should actually just do the surgery and go in and clean it out surgically. This is one, in my opinion, that just needed that. And actually he did, and this person actually did very well, but definitely needed to be opened up and cleaned out kind of globally, from the whole tendon.
Would you ever do like a combination therapy once it was cleaned out? Like, would he require any orthobiologics or anything like that in addition?
Well, I would have used orthobiologics had I been the surgeon cleaning it out. In fact, when I do like patellar tendon or quad tendon or cuff and we do calcification, absolutely what we do is we'll clean out the calcification. And then once we get it cleaned out well enough, and then we're going to have to re-repair the tissue down, I'll infiltrate the PRP, trying to make sure that it's going to heal well. But yeah, but will I do follow-up injections? No, that's controversial whether that's of benefit or not. PRP after surgery is good for diminishment of inflammation and for pain, but does it help with healing? Unless you're going to go right back into the tendon under ultrasound and re-inject the tendon, I think bathing the tendon is of no use. But going into an area of healing potentially could be, but again, as I said, controversial, so I can't necessarily say that's the way to go.
Right.
All right, so here's an example of doing an in-plane longitudinal, long axis type of injection on the Achilles. And this works. This is one of my early ones I did a long time ago. I think this was like 2009, 2010. And I quickly changed my technique because I found, even though this is like the way that was traditionally taught of how to do it, it was really tough to do. And the reason why is because trying to get your angle and change your angle of approach, you're being inhibited by the leg. You're being inhibited by, your ability to get in there and see. So this is not something that I can really in good faith say is the best way to do it. I actually discourage this technique now, but this is kind of like how everyone used to do it. I mean, have you seen other people do it this way still?
Yeah, I mean, I see a lot of people still insisting on doing that in-plane long axis approach, and when it wasn't until I saw you do the short axis in plane that I was like, a light bulb went off, and I thought, well, this is brilliant. I mean, you just much easier access, and you can see where you're going more. And yeah, it just made way more sense to me.
Yeah, so this is how I do it now. And so what I do is I do a short plane injection. So what it does for you is it allows you to, number one, get to different parts. So if you want to go, very much posterior and infiltrate paratendon, you can. You want to go into a specific area in the tendon, you can. You can, as you see here, going above kind of going superficial. You can dissect along that plane, making sure you can dissect around it. You can get down below it, as you said earlier, behind above the fat pad. You can also then move your scanner proximal or distal and get to different areas as well. To me, this is just easier, and it allows a lot more flexibility with the kind of injection you're going to do. And you don't have to then pull the needle out and go a different area. You can just do it all from one area and not have to poke them 5 million times. So yeah, this is definitely my preferred method now of how I do things. So short axis, in plane, that's what I like to do. But for me, as I've said over and over, ultrasound improves accuracy. And I just find how much people just still don't believe. And it's like, it blows me away. And what's funny is like, the more that you do, you'll notice that all of my needles are fairly easy to see. But what's interesting is I do not use special ultrasound needles. I just use the basic needles that I have in my office, and they're usually 22 gauge. And as you can see them very well. And the key is technique. That's really the key, is knowing how to stay parallel, how to stay flat. Once you start angling, you can get that special magic angle. In fact, where it can even disappear. I think that's 27 degrees, Shelley, 24 degrees?
Yeah.
There.
Yeah, something like that, yeah.
Once you get past a certain angle, the beams will hit and bounce off this way. They won't bounce back. And so you will actually completely lose your needle. Like you won't even see anymore, as if it's not there. It's like magic. It's just not there. But yet if you're parallel, and you're perpendicular to your beam, but you're parallel with your transducer, basically you're going to see it pop. And that's really the key to being able to do this properly and being able to do it easily. And if you can just always be behind it, watch yourself come in, get under it, it's going to be simple to do and you'll hit it every time. And also bringing the needle to your pathology, not bringing your scanner to your needle, that's not the way to go. So just learn how to always work with your needle wherever you are, not going to your needle if you can. And we've seen all these studies before. We've talked about them before, how it's so much more accurate to use ultrasound. And of course, my own experience, how my patients have so much less pain. And realistically, I realized I was missing. That's the whole point. Okay, so here we are, Shelley. We're in the lab and showing examples of how to scan. And you can see those fibers really nicely of the Achilles.
And I have to tell you that I was blown away at how well we could see everything. I was a little bit nervous, not having ever scanned in a cadaver lab before, and definitely it was fantastic.
Yeah, it's easy. And what it is I would encourage anyone watching that's learning, if you're not sure, obviously going to, and you can see here we are going in with a needle, and you see how easy it comes in. You can see it very nicely. And if you can go into the center of the tendon if you want to inject it. You can go, superficial to the tendon near the skin and inject it. Really easy to do, or get back behind it, whatever is necessary. Just working in that plane so you can really get into it. I would really encourage people. I actually found that those Jello fruit cups were some of the easiest ones to work with, and they're cheap, and so if you're wanting to practice and you don't have access to a cadaver lab, using a Jello fruit cup works great. Inexpensive, and being able to go in with a needle and find what you want to do is great. So this is easy stuff to do, and just all it takes is just practice. I'm cheating here, as you can see. I should be back behind it in plane looking down the middle, and I'm not. And it's just because I'm messing around. But when you're doing it, you should sit behind it and watch it go in. That's usually easier. Any other tips you have for people, Shelley?
Yeah. So you mean just so that you're lining up the scanner face with the length of the needle? Is that what you mean?
Yeah.
By being behind it.
So because I see a lot of people, like, they'll take their scanner, like, here's my phone. Let's say this is my scanner, and they'll sit where I am, and they have the scanner here, and they'll be like injecting this way. And exactly.
Right.
It's like this is impossible. So what you got to do is you got to get the scanner like, in front of you, and then get your needle behind. And so that you're sighting down the needle like a sight. So you can see that you're directly under your scanner. That's really what's critical. And that's the most important thing to doing these. Otherwise, yeah, it's hard because if you're trying to shoot this way, oosh, set yourself up for success. Don't make it hard on yourself.
Yeah, and I think if people remember, I mean, that sound beam is about 1 millimeter thick. So if you're not directly in the sound beam, you're not going to see your needle. So I like your point about take your needle under the scanner. Don't go kind of scanning around looking for your needle. Like move one or the other, but not both. That's really helpful when you're trying to visualize your needle as well.
And if you're trying to learn, get a credit card out. Get a credit card out. Just get a credit card out and get your needle and try to stay in under the credit card 100%. And if you can do that, I guarantee you're not going to miss your needle. It'll be easy to do. So that's a way you can like get used to doing it. But I'm serious, those Jello fruit cups are fantastic. I mean, we ran a course one time where we had a low budget. And so we just bought like 4 dozen fruit cups, and we just had them available for people to scan in and nail stuff. And they're like, yeah, just hit the peach. No, hit the pineapple. Go, cherry.
We used to do a thing called find the pimento. So you'd put an olive in the Jello or a chicken breast and an olive with a pimento in it. And if you got pimento, you won the prize.
Exactly. Yeah. So lots of things you can do that aren't expensive, that the ways to learn. Chicken breasts work great. I remember we did a course in Hong Kong, and actually they got us pig feet, and we were scanning like pig's legs, because that was what was cheap over there. And I'm like, okay, great, whatever works. All right, let's move on. So now let's talk about Achilles tendon ruptures and PARS repair using ultrasound guidance. So this is really interesting. The way this kind of came about was many years ago. I was actually in the OR, and one of my little friends who's a podiatrist, we were talking about Achilles because one of our buddies just had his Achilles rupture. I'm like, hey, so do you use that PARS technique? And he's like, no, I don't like the technique. I'm like, why not? It's like, well, because you can't tell because you're going percutaneous whether or not you're actually in the tendon or not. And I'm like, well, why don't you use ultrasound? And he's just like, and we went in the lab and I showed him how to do it. And he was just like, he was so upset with himself that he never thought of himself. And I'm like, this was many years ago. And he was just like, oh my God, this is crazy. I'm like, yeah, it's easy. So in case you don't know what a PARS technique is, it's a percutaneous method to pass sutures through an Achilles, so you can repair the Achilles either mid-substance or near the insertion. And this is done through a minimally invasive single incision, and all the other incisions are very much superficial. And so the way it works is they have this jig, and the jig goes in and kind of like sandwiches the Achilles, and then on the outside are these 2 other bits that are attached, and you pass these needles across through, passing the suture in and out. And then eventually what it does is allows you to pull those sutures out through your tiny incision down here and then attach them into the calcaneus down here. So the big problem, of course, is making sure that when you pass your needles, that the needles pass through the actual tendon. Because if you're holding your jig and your jig is too far anterior, too far posterior, when you pass your needles, the sutures won't go through the actual Achilles itself because you're doing it blindly, technically, right? And so that was what people had problems with. So using ultrasound, there's your Achilles. You can see it, like you see the full thing. In fact, on the ultrasound, you can even see the bars holding it to the side. And here you can see my assistant Kelly passing the suture, and you see the suture the needle went right through the dead middle of the Achilles. Okay, so I've clearly got it correctly oriented. And so there you go. So you can see the needle, and now we're going to pass that needle, pulling the suture through it to the other side. And this is all percutaneous. So like there's no open incision here. This is just being done through the skin, going in. You can see the suture, and then you can see the suture even sliding back and forth inside that Achilles. And so we'll go to the next one. Now, here, what we're going to do is I'm going to show you, and I'm going to intentionally torque and push the guide too far anterior. And so what you're going to see is as the needle comes across, the needle's going to come across and it's going to be actually not even in the Achilles. It's going to be anterior to the Achilles. So here we go. And you can see that needle there coming across, and you're going to hear in a second. There you go. There's your needle. That is not in the Achilles. That is anterior to the Achilles. That would be a terrible throw. That would make it basically non-functional suture. It would not be holding the Achilles itself. That'd be like in fat. If not, it might be in the small aspect of it anteriorly, but not enough. So this allows us now, see, there you go. I've reoriented the jig, and now I'm coming right through the dead middle of that Achilles. And that just makes it so simple to do. This surgery becomes really a no-brainer. It's such a quick procedure now doing it this way. And so the technique requires about 5 or 7 sutures passed back and forth. And then once all that's done, you guys can look at the technique online and you can see how you just pull all those sutures out down the bottom. But yeah, that's literally it. I mean, it's just that simple. So there's not a lot more to say about this. It's just simply a matter of being able to visualize, know where everything is, so that you basically get it right. Have you seen this before, Shelley?
I had never seen this before, and I thought it was one of the coolest things I've ever seen. And just to be able to be that precise about where you are in that tendon. I mean, I tell you, if it was my Achilles getting repaired, I think I'd want you using ultrasound.
It's a no-brainer. It just makes it so simple. And you can see it right there, and then you can always go back and verify. You can actually still see the suture in the tendon, so you can always verify if you're in the right spot or not. So even though this is not done arthroscopically, I think personally, ultrasound is just another tool in our bag that we can use surgically to just get the job done better. So whether it's an arthroscope, a C-arm, whatever, ultrasound, it just helps us get the job done more efficiently. And that's why I think this is critical to do. So that's really about it. At this point, and I've said this now, I think 1 million times for summary for ultrasound, it's a tool, nothing more. People think it's going to replace MRI. It's not. It does something different. In some aspects better, in some aspects not as good. It's a tool like fluoroscopy and arthroscopy. Will it replace arthroscopy and fluoroscopy? No, because those things do things that it doesn't do either. It's inexpensive, widely available. It allows for visualization of anatomic structures. And as long as you can visualize it, you can help it guide you putting injections or doing your surgeries, whatever you have to do. And it can transform surgeries from open procedures into percutaneous procedures or even arthroscopic. That's about it. Thank you very much.
Great. I'm so excited to see where we'll be in 5 or 10 years. Surgeries are going to be better and less invasive. And it's very cool stuff. I have a model that I'm going to do a little demo with the L15 scanner, the one that Dr. Hirahara was using. So I'll just head over to the bed here and I'll show you the Achilles tendon. So one thing I want to just kind of say right off the bat is when you're scanning the Achilles, just because there's a little bit of a curve in here, I like to hang the patient's foot off the edge of the bed or put something under their ankle just so that it's you can kind of straighten out this tendon a little bit. And the other trick is to use lots of gel. Don't be shy with the gel because you need good contact, and the surface of the Achilles is a little bit bent. So I am using the L15 scanner, like I said, in the foot ankle preset. And so I'm just going to start just down at the calcaneus, and we'll find, let's switch around here, and we'll just locate calcaneus and the insertion. So there's the heel right there, nice bright white. And we can see nicely how the Achilles just inserts right onto that bone. And I'm getting a little artifact, it's dark here, called anisotrophy. So we've talked about that before, and that's where the muscle fibers are just kind of veering away from perpendicular to the sound beam. And all I have to do is just tilt my scanner a little bit and I can get rid of that.
And Shelley, if you don't mind me saying before you move that scanner, One thing that you're doing that I think people need to note, if you move back to the calcaneus, look how bright the calcaneus is. And the reason why it's so bright is because she's perfectly perpendicular to that surface. And that's a key thing. Number one, it helps you as the user, as a scanner, know if you're in the proper orientation or not. Always look for the white highlighted bone, and that's going to help you get the best image for your other structures. Would you say,
Right.
Kelly?
Absolutely. Yeah, absolutely. Yeah. Perpendicular, not necessarily to the skin surface, but to the structure that you're looking at. And that's going to optimize your imaging every time. So I'm just going to slowly slide toward the patient's head here. And we're seeing the Achilles tendon all along here. And you can see the nice fibers all along. And like I said, it's a nice, big, thick, juicy tendon, very easy to see. And I can scan up. Still seeing it here. And we can go all the way up until we get to the musculotendinous junction, which is right. It's just tiny here. And then here's the muscle down here. Great. So at this point, I would turn my scanner 90 degrees and start up as high as I can still see the tendon, which now is here. It's very flat structure. And we'll slowly scan down. And again, I'm just making sure that I'm staying perpendicular to that tendon. If I go off of perpendicular, all of a sudden the tendon looks dark, might be mistaken for pathology, but we know that it's not. And I'll just continue down. And all the while, just making fine-tuning adjustments. And we've got a nice normal looking tendon, would you say?
I think that looks really good. I think, Shelley, you glossed over a key point I think that you need to tell our listeners is that, you're doing this almost without thinking. But the key here is that you said it right there. You're making minor adjustments as you go. As a new scanner, people will just throw the scanner on and think they're in the right spot. They're doing great. They see what they see. Always make these minor adjustments of tilt and of your scanner, up and back, side to side, and find the optimization of your image. Don't accept that what you're seeing is quote unquote best. And also, if you're seeing something that looks like a tear, it might be that anisotropy. And so by tilting back and forth, if that disappears and you now see tissue, that was an artifact, not a real tear. And so that's really, I think, a critical key point in learning how to scan properly, and then being confident in what you're looking at. Would you say, Shelley?
Yeah, absolutely. And I think, like I mentioned at the beginning, the Achilles is a great place to start because it's a tendon just like every other tendon in the body, but it's big and you can really get a feel for what it's supposed to look like and what those fine movements will do for you. So yeah, I encourage people when they're starting to image tendons just to have a look at the Achilles for starters, and it's just a good place to start.
The other thing I think, which is you're showing very, very nicely and well, is the fact that the tendon is not just some uniform, solid structure. It's made up of fascicles and fibrils and different parts. And now with the high definition scanners that we have available now, which is not like it was 20 years ago, you can actually look at the architecture of these structures and help diagnose better what you think is right or wrong. And that's what I think is just so helpful for me. Granted, I'm a surgeon, but, in dealing with sports athletes, they're not all surgical cases. And being able to better define the pathology to that athlete and then assess whether or not they're going to get back sooner or later, I think is critical. And I think that's what gives us that ability to see the architecture.
Yeah, definitely. All right. So now if I'm kind of mid tendon here and I'm wanting to come in, from the lateral aspect, like Dr. Hirahara was mentioning, I would, line myself up with the scanner this way, and then insert my needle over here, and making fine tuning adjustments as to whether I want to go shallow or deep or or whatever. But it's just such an easy access to that tendon for me, doing it that way that, I can't imagine doing an Achilles injection any other way at this point after seeing that.
Well, the other thing I think that you have to show them also is how you have to cheat. So, for example, you've kept that tendon in the dead center of your image the whole time. What I do is I actually move the scanner out of the way, and I'll move the scanner either to the side, and I'll bring that tendon to one of the sides of my image so that I'm not going to contaminate my needle as I come through. Now, if you're going to keep the center and you're going to have that potential for contamination, that's when you do need to use an op site. You do need to use sterile technique. You need to use sterile gel. But if you're careful, that's not necessary if you're cautious with how your technique is and not contaminating your site of injection.
Excellent. Okay, and one last thing I want to just demonstrate for everybody here is a new feature that's the FDA approved, and it's something called MSK AI. And it's a feature that is really going to be great for learners. There's a little AI icon on the side of the screen that I'm just going to tap on. And what happens is the app will analyze the tendon, identify it, put a nice overlay over it. I can adjust the opacity of that overlay to my liking. And then when I freeze the image, the app places a caliper over the thickest part of the tendon. I can make some fine-tuning adjustments. And the other great thing is that it labels the Achilles tendon and gives me the measurement there. So like I said, this is great for learners. It's also great for experienced users who are following up on serial ultrasounds on patients if they've got a thickened tendon. So yeah, just a great new tool that's soon to be available.
Yeah, when I first started using this and looking at it, I thought for sure that I was not going to use it ever, because I thought it was going to be something that was purchased for new users. And I was blown away when they added that ability to, automatically through AI determine the thickest part. That actually is a game changer for me, especially in doing research, because it's going to take inter-observer reliability out of the equation. And so we can more reliably, I think, figure out, we can rely on these measurements that we take for research to follow patients through. And it's going to help, I think, long term as you guys just make it better and better. So yeah, thanks.
Excellent. Good. All right. So I encourage everybody to continue asking your questions using the Q&A, and I'm just going to hand it back to Janess.
Thanks, Shelley, for the fabulous demonstration. And thank you, Dr. Hirahara. We really appreciate you working with us on this cadaver webinar series on how to ensure highly accurate and precise MSK injections by sharing your expert ultrasound-guided techniques with us. Before we open up the floor to live questions, and I see there's dozens here, we are going to provide a quick poll. We'd love to help everyone continue their journey in bringing handheld ultrasound guidance to their practice. So please complete this poll to let us know if we can provide further information. And do click on as many options as apply. Pricing and availability does vary by region, so please request a quote to learn about local pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option. You can book a virtual one-on-one demo with our experts to see the new Claris HD3 in action in a highly interactive one-on-one session. So if you're looking for something more interactive than what you had today as an experience with our webinar, please select that option. And we can send you more video tutorials, some of them by Dr. Alan Hirahara himself. So if you'd like to see some more videos and continue on your learning journey, please select that option. You can go ahead and select as many options as you wish. While you complete the live poll, I'll take a minute to introduce you to Claris HD3, the world's only third-generation line of portable ultrasound scanners. Now 30% smaller, lighter, and more affordable, Claris HD3 delivers best-in-class wireless ultrasound for pain management with an easy-to-use app powered by artificial intelligence and connected to the cloud. Our Claris linear scanners are specifically designed to effectively guide pain procedures with superior MSK and needle imaging. They deliver several advantages. Claris is unrivaled for near-field and high-resolution imaging in a handheld device. As you saw today, you get clear view of nerves, vascular structures, and other anatomy, and your needle for safe ultrasound-guided injections. The secret lies in each scanner being designed with 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality only found in compact systems, but at a fraction of the cost, representing 85% savings and more often. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. Clarius is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. You get free movement with no wires getting in the way and touching your sterile prep area. And with no wires, Clarius is also much faster to clean and disinfect or fully encased in a sterile bag. Only Clarius delivers linear scanners with an ecosystem that includes a free app for your iOS and Android devices for unlimited users. Available with our new membership, Clarius Cloud is used to easily capture and manage unlimited exams from anywhere. Your membership also includes in-app Clarius classroom videos with experts like Dr. Hirahara and onboarding with a Clarius clinician to build your skills. Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. And with your membership, you also get our advanced MSK package that includes dedicated presets, a variety of automated tools, and soon in the USA will feature the FDA-approved MSK AI feature that Shelley showcased today. So we have received FDA approval and it will be available commercially in the US very soon. It automatically identifies, highlights, and measures the thickest section of tendons in the foot, ankle, and knee, accelerating ultrasound mastery for new users and hastening diagnosis and treatment of musculoskeletal injuries. Regulatory approvals for this feature are pending in other geographies, and it will soon be commercially available in the USA, so stay tuned. Now we can close off the poll in 3, 2, 1. Thank you. If you ask for more information, we will get back to you in the coming week. I'd like to welcome back Dr. Hirahara and Shelley to answer your live questions. Please use the questions in the icon menu bar to ask your questions of our great clinicians. Shelley, if I can ask you to moderate, please.
Yes, of course. Okay, we just have a few minutes left, and if we don't get to your question, we will get you an answer in the coming days. One that's kind of funny is, how do you get anyone to sit still for a 22 gauge needle?
So that's an interesting question, because actually when you're doing biologics, you can't use a lidocaine, injection beforehand. So yeah, it hurts. And I said very clearly, like I showed you my Achilles, that hurt. It wasn't the most fun. You just have to pretty much tell them it's going to be over quickly. But the advantage of ultrasound is you see her going, you're in, you're out, get it done, and just move on. And yeah, just say, here, bite down on something for 5 seconds. We'll be over quick. It's a good question. It really is. It did hurt. I admit it. When you go intratendinous, it doesn't feel good. It's true.
All right. Since PRP injections require low gauge needles, how likely is the risk for an iatrogenic tendon tear? Should the injection be placed intra or peritendon region?
So a bit of a misinformation there. You don't need to use small gauge needles. You can use, a 22 gauge needle. Some people say you have to go up to, 18. That's not true. 22 is just fine, in my opinion, and using even 19 if you really want to, but I use 22. As far as causing intra substance damage, you're right. But the thing is, it's already damaged. So you're just injecting in the tendon to kind of give it something to try to get it to heal. But yes, you are causing damage. So you're going to want to be careful in your rehab protocol to make sure that you don't do more harm. But that's why using a biologic is safer than the cortisone, because not only are you doing damage, but then the cortisone might not let it heal as well. Because as you know, cortisone inhibits healing. So that's another issue, is that's why you don't want to do cortisone prior to surgery. There's been recent studies showing that cortisone increases risk of failure of surgeries. So again, why you want to stay away from cortisone.
Right. Lateral approach for injection of Achilles tendon can potentially damage the sural nerve. I always go medial approach. Do you have a comment on that?
I agree. Yeah, absolutely. 100% agree. Yes. And I saw one of the other questions asking a very similar question about sural nerve injuries during PARS repairs. Correct. I don't have a lot of experience looking for the sural nerve because, as I've said, I'm a shoulder and knee specialist. Shelley, you're the sonographer. Can you see the sural nerve?
Yes, if I really spend the time to look for it. Yeah.
And I believe that is possible, but can it be damaged? Absolutely. I don't doubt that at all. But I think it's going to be safer doing this under ultrasound than not. So that's my response to that.
All right, great. Well, I think we are at the top of the hour here. So just to be respectful of everyone's time, we'll say thank you, everyone, for attending this fabulous webinar. Thank you, Dr. Hirahara. Great information as always.
A big thank you to Dr. Hirahara for sharing all his best practices, and a very big thank you to all of you for joining us today. I hope you have a wonderful rest of your day and keep scanning.
Thanks, everyone.